this is not about mental health. This is about brain health because it comes from here. I just wanted to learn what supplements to use first and so forth. But I figured there was more to it than that. When I was using it the other way, finding the medicine for the patient, it wasn't getting the results that I needed. And so I think that's also where the idea that it is genetics. Mental health is a genetic issue.
Welcome back to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. Today, I'm your host again. My name is Dr. Scott Scher. It's a pleasure to be back with all of you. And my guest today is Dr. Mizyl Damayo. She's a friend, she's a colleague, and this is the first time she's ever done a podcast before. And I was so excited to be able to host her for it because she's got so much amazing information to give all of you as a precision psychiatrist, as she likes to say. This is like the next generation of integrative psychiatry overall. So here's a quick bio on Mizyl. So she's a dual board certified psychiatry and substance abuse practitioner. She's an MD. She's created the Brainwell program and owner of Paradise Behavioral Health in Florida, where she brings an expertise in precision psychiatry through integrative approach to treat mental health that puts an emphasis on healing the brain and non-medicated treatment. We had a really great conversation here, something for everybody that's a practitioner for sure, and those of you that are listening that are on antidepressants and antipsychotics. And she has an amazing framework that she's developed over many years. It looks at genetics and nutrigenomics and nutrition and hormones and brain inflammation. She talks about her path to getting there and understanding that work. And she's one of the few docs that I know that's doing inpatient psych at the same time as she has an outpatient integrative practice. There's very few people like her. And she's got this great approach. Some things I learned that I had not known before this podcast. One about brain-derived neurotrophic factor and how this is usually depressed in traumatic brain injury and oftentimes in bipolar from genetic reasons. And she gives them lithium even in traumatic brain injury. And these patients do better, even lithium orotate and not even the prescribed type of lithium. We talked about how you can wean patients off of antidepressants over time and the various strategies that she uses. Of course, most of these strategies include optimizing their health of their brain. She talks about how mental health is brain health. And I think this is so important for those that are listening. We all know this intuitively. She does talk about psychiatry and psychotherapy and that piece of it. We touch on ketamine and psilocybin. And we got to talk about many other topics, including transmagnetic stimulation as well, and how she uses TMS in her practice for depression, for anxiety, which is actually really challenging to treat overall, and also PTSD, and referring out when other people need it. So this is a very comprehensive and interesting conversation that I know many of you are going to love. So enjoy, have fun. And if you like our podcast, don't forget to like and subscribe below so you never miss an episode. Now, without further ado, Dr. Mizyl Damayo on her demonstration of the power of integrative and precision dose psychiatry in her debut podcast. Enjoy. All right. Mizyl, hello. How are you?
Hey, Scott. How are you?
I am fantastic. It is so great to have you on your first podcast, which is so exciting for me. I remember my first podcast that I recorded. It was back in 2016. So it was a minute ago.
Yeah.
So I know that it's a different way of describing and communicating. But like I said to you before we started, we're just going to have a fun conversation here about all the amazing things that you do in clinical practice. So I really appreciate you being here with me and becoming your first podcast to be on. I'm excited.
I'm glad it's you, Scott, because, we've kind of become quasi friends.
Oh yeah. Yeah, definitely.
I really appreciate all the support you've given me and great advice. On how to maneuver this, because I always said I want to be like you when I grow up.
We don't grow up. We're Toys R Us kids over here. So what I really was intrigued when we first met was that you were the first person that I had met in the integrative psychiatry field that was still seeing patients in the hospital, I think inpatient psych ward, and was creating an integrative practice. I think for me and maybe the audience, how did you make this jump? How did you go from being inpatient psych to describing your practice now as an integrative one? And what was that evolution like? How did you get there?
Before I got there, I was about 10 years into practice. And, here I was, I mastered my DSM, mastered my syndrome. I know every med for whatever. And I know even what med to use for side effects. but I still really didn't feel like I was getting anywhere with my patients. And I thought like there must be something more. And I started thinking, you know what? I'm not really focusing on people's lifestyle, what they're eating, what they're still doing to themselves. And they're just expected to come in and for me to figure out how to help them. And I realized it had to be more of a team effort. And so I went on this route where Dr. Amen actually opened my eyes because he was one of the first people that really turned me on to like integrative psychiatry. And the first lecture he said was like, this is not about mental health. This is about brain health. And I was like, yeah, because it comes from here. So here I was. I just wanted to learn what supplements to use first and so forth. But I figured there was more to it than that. And then so I really started delving into genetics a little bit differently than other psychiatrists. Most psychiatrists will look at it and say, okay, this is what you need and what you don't need and so forth. But I started looking at the pharmacodynamics. And because like when I was using it the other way, finding the medicine for the patient, it wasn't getting the results that I needed. Started looking at pharmacodynamics, like what patients are prone to from the beginning. And so I think that's also where the idea that it is genetics, mental health is a genetic issue. We always say that, but nobody ever knows the answer. But now I think we do have it. You know, there are people who are poor metabolizers of certain vitamins, not just folate, but B12, as well as poor absorbers of even just simple vitamins like vitamin D. Because if you are low in that, it's not just immune issues. It can lead to depression because of the new idea, which really was not new. I think I even heard about this in 2006 called cytokine sickness syndrome. And I was like, yeah, this is it. And people looked at me like I had two heads.
Yeah.
Because they didn't understand that there is a inflammatory process that plays a factor in depression. So if you ask me like how I really got into this, because I really didn't feel like I was getting the results I wanted my patients to have. I wanted them to be happy. I wanted to feel whole. And I wanted them to say, you know what? I am back to who I am. And I never got there with standard psychiatric treatment, which is psychotherapy, medications, and what we know as ECT. And all those are good and dandy. But like the more I read about it, like no one told me, did you know there is a 55% failure with medications? I was like, what? And I'm sorry, but like when I was in training, the drug companies came in and I thought, oh, this is the way we need to practice, figuring out what drugs, this and that. But even then, I think I was working with Dr. Gordon and he asked me to do like the mental health part of his traumatic brain injury workshop. And I was like, what? The FDA only requires 15% success and that's it? But what happens to the 85% or so suffering? So I figured, you know what, there has to be more. And then as I figure, let's think out of the box. And so, yeah, the new theory behind why we have treatment resistance is inflammation triggered by physical assaults like head injuries, car accidents, physical abuse, domestic violence. But then that also triggers an emotional reaction in people. And guess what? It is the same chemical reaction in the brain. You know, release of these cytokines, and it is protective at first, whether it's you play football or whether you are continuing to be in a toxic relationship. It does the same thing to the brain. And so I think that was the biggest lesson I learned in that, you know, what are these supplements doing? So now we know that we have to use it to get the brain healthy. That wasn't the end of it, of integrated psychiatry. I got into this thing called precision psychiatry. And I was looking at my modality of treatments like, this is more what I do. I have to do the data. Let's look at your genetics. Let's look at what you're prone to. A lot of times, people who don't recover well from a brain injury is because they may have a poor ability to make certain brain proteins, especially the brain-derived neurotrophic factor. And I've gotten great results with just using natural things to increase that in patients with traumatic brain injury. Didn't have to go through medications. That was really revolutionary for me. And that's what I was talking about, going into learning about pharmacodynamics. So now I don't just throw a bunch of supplements at people, because when I did that, they were like, oh, this is not good. I'm not handling this very well. So I had to figure out which ones to give and which ones to avoid. And that's where precision psychiatry comes in. But you have to use both, because you have to have the knowledge of what to give patients. And then also have the knowledge based on your data, what you really need to give them and what you should avoid. Because sometimes what you think is a great supplement may not be the best for the patient. And then I didn't understand this before I really got into the genetics and precision part of it. Because, here I am, oh, okay, this is your problem. And this is what you need to take. And they come back going, I'm getting anxious. What's wrong? And I go, that should have worked. Right. So I'm like, okay, let's take a step back. It's really kind of interesting, because I have asked some of the smartest people in my field, they know a little bit of integrative, but they still couldn't give me the answer. So I had to go on my own path, my own journey. But maybe that was the best thing, So
that's beautifully said, Mizyl. I think our paths are so interesting, right? In the sense that many people that get into integrative medicine have had their own experiences where they've found that they themselves have been failed by the medical system in some ways. But there are people like you that have seen that their limited amount of knowledge that they thought was a lot of knowledge at the time is only getting people to a certain degree. And then they realize that there's so much more out there that can help overall. And that it doesn't mean that the treatments that you were using in your residency and in psychiatry before you started doing more precision medicine weren't helpful to some degree. But I think what you've realized is that they can be very much more precise in how you're using them, depending on looking at genetics and looking at nutrigenomics and other aspects of how to support the system. And so you mentioned a couple things that I was hoping we could just talk a little bit about. One would be, because I don't know, it was called cytokine sickness syndrome. Tell me, what is this? I haven't heard this concept.
Really? Yeah. It's really just an inflammatory process that happens when you're going through a lot of stress.
Okay.
And so this can happen with chronic brain injury, chronic trauma, chronic people in abusive relationships. So it's protective, right? In the beginning, once the stress is gone, it's supposed to go away. And what happens is when you have total inflammation after inflammation after inflammation, and the immune system doesn't know when to shut down.
Right.
And then it causes, when you talk about inflammation, there is a chemical reaction in the brain that happens when you're full of inflammation. Your serotonin, dopamine, norepinephrine production goes down. And then also even GABA goes down. And I think, you're a big proponent of GABA, and I could learn so much from you with that. And then, but it's not only that, glutamate. We know about glutamate, glutamate and GABA go together.
Right.
So what happens with inflammation in terms of the brain and mental health? The inflammation increases glutamate. So no wonder people are anxious.
Yeah, this is so interesting because I remember hearing, when I was doing research on GABA, when we first started working with products in this space, was that OCD and schizophrenia are associated with low GABA levels overall and higher glutamate levels. Is there like a significant inflammatory component typically that you see as a result of these kinds of brains that have benefited from working on the inflammatory pathways, and then you see improvements in the other kinds of neurotransmitters too?
Yes, because I do more clinical work. I don't really analyze levels of serotonin, dopamine. And,
of course.
And
it's hard to...
I've looked... Yeah.
And you can't really do it. Yeah.
Exactly. And it's, that's very scientific. Even analyzing those things is not always accurate.
Of course.
And it doesn't always display in the patient. You have to just think about the patient and where they are. When you're asking about OCD and schizophrenia, my theory is that I find, even in autism too, that they have low dopamine metabolism. And so that increases dopamine when you get anxiety, psychosis, and I can't say the number for sure, but there's a rampant number of increased psychosis in general population. Why? because we have allowed medical marijuana. I am not going to say that you shouldn't, but this is where precision comes in. If you know you have a family history of it, then please don't do that.
Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out our metabolomics module. This is our foundational module. It's our framework to look at how you can optimize health rather than treat disease using vitamins, minerals, nutrients, cofactors, cellular health in real time, clinically actionable. We can do things right now to help our patients, looking at our environment, our genetics, and everything in between. Go to homehope.org and save 10% on this module or any module by using code podcast10 at checkout. Now back to the show. So medical marijuana, for those that are listening that don't know, it raises dopamine levels then.
Yes. Yeah.
Okay.
And unfortunately, because I do work in inpatient unit, it's just sad because like these young guys, they were doing this since they were 13, 14, and their brains have just gone mush. And I love inpatient work, the acuity and all that, but I feel bad for these people. I really wish I could offer them what I can do to say, hey, you know what? I think the problem is you got to get your brain healthy and you got to eat a certain diet based on your genetics. But they're only coming in and out, and which is to me is like kind of sad.
Yeah.
But that's the state that we're in.
Do you ever get the opportunity to work with some of these very sick patients that are inpatient and then encourage them to come to your clinic and do some comprehensive work with you?
Yes, some of them, especially the ones that they're not so much like psychotic, but then, they've had treatment-resistant depression. And I'm talking to them in the inpatient unit, and they're like, no one's told me about genetics. No one's tested my vitamin levels and things like that. And the funny thing is, when I started working there, I was constantly writing vitamin D level, B12 folate, thyroids and all that stuff. And then after a while, they're like, okay, Dr. Damayo, we're just going to put that in the protocol. I'm like, thank you.
Yes.
Thank you.
So everybody gets it when they come in the door. You have them take a battery of supplements typically?
Yes. And it's so phenomenal to see people come in with vitamin D of 7. I'm like, that's the problem. I mean, it's not the main problem, but like
certainly not helping.
Yeah. And if you're low in B12 and folate, you're not going to be able to make your own serotonin or dopamine, because in that cycle, that's needed. It's been a long journey for me, but it's not over yet.
Of course, yeah.
Yeah, and I'm going to ask your help, Scott, because like you've really done a lot for me already to guide me what I need to do. So anyways.
No, all good. I think, what I'd say here, and I appreciate you saying that, the journey coming out of hospital medicine and conventional medicine isn't an easy one for any practitioner. And those that are listening, there's probably many that can relate in many ways. And many of us also can't just proverbial burn the ships and stop doing conventional practice because we have families and we have, quote unquote responsibilities and all those kinds of things. And so it's certainly been a slow process for me. But I think what I found so interesting about your work, working with Dr. Gordon, and then your precision psychiatry, it's like the next level really from even what integrative psychiatry would be. So typically, as you would say, like I found some integrative psychiatrists over the years that maybe test them vitamin levels and do a couple things like that and put them on some of that work. But what I found really interesting, and I thought maybe we could go through like a very common example in your practice. So I know you see a lot of people with traumatic brain injury. And I think I loved something you said to me recently, and I say this all the time, is probably the first doctor to ask them if they've even had a head injury before, right?
Yeah. Because these patients, sometimes they don't even know.
Yes.
And then it's kind of fun, actually, to get to that story with them.
Yeah. Their chronic headaches, like their difficulty concentrating, all these sort of mental health type symptoms, where if they had gone to like a conventional psychiatrist or their primary care doctor, they would have gotten a benzo or a sleep medication, or maybe just an antidepressant straight up, right? And where you're like, well, did you ever get hit in the head? And this is something that in the world of hyperbaric medicine was a phenomenally surprising thing to me too, where I would start asking them the question like, oh, nobody's ever asked me that before. And it was like the second question out of my mouth after what their name was kind of thing. So, so I know you work with a lot of patients with traumatic brain injuries, and some of these people didn't know they had a traumatic brain injury ahead of time, as we were discussing here. So let's go through your framework, because I think it'd be good to talk about. So like somebody comes in your office and they have symptoms, and then you say, you know what, you didn't know it, but when you were 14, you fell off your bike, you hit your head, you had a brain injury, and that could be contributing to some of the symptoms that you have now. Like, what is the next step? Do you ever send for imaging? I know you talked about Daniel Amen before. Do you ever go that route, or do you kind of focus more on starting with the laboratory part of things?
Yeah. I find that we don't necessarily need to go to imaging because I'm in the school with Dr. Gordon. That doesn't really tell me anything if you've had chronic traumatic mild brain injury.
Yes.
So it doesn't really show much. And SPECT scans are great if the patient can afford that, because most of the time there's not a lot. I'm not saying there's no value, but a lot of times the medical world, psych world, they don't really put a lot of value into it. So I'm also the simplistic kind. Let's do what you can do. Let's run your genetics. Genetic testing can be pretty affordable, believe it or not.
And so what are the common things? So you start with genetic testing. This helps you with what you talked about, the nutrigenomics aspect of things as well. Like, what are some of the common things that you'll see? I think you've mentioned a couple, but what are some of the common ones that you see in a TBI patient or maybe another patient population if there's not as much to say in the TBI patient population? Yeah,
there's three main
areas,
genes that I do look for, like the BDNF, the MTHFR, and the COMT gene.
Okay.
They are actually integrated together because if you don't think about all of them, and sometimes the treatment is kind of similar to them. So I was looking at BDNF and I go, what is that? And then there was this lecture by a super uber genius pharmacist. I was like, oh my gosh. And sometimes I think people who are low BDNF, I sometimes call it the bipolar gene. Why? Because they will respond to lithium. Lithium will increase brain-derived neurotropic factor. BDNF is basically the fertilizer of the brain. It helps create healthy brain cells, healthy connections, healthy differentiations. So I'm thinking there are patients out there that are bipolar, that go way up there. And I hear it too in training and in the hospital, or even in clinical setting. They only respond to lithium. I'm well, I bet you their brain-derived neurotropic factor is a little bit poorly produced. And this is very important to look for in terms of people who've had traumatic brain injury. Maybe this is the reason why that some of these patients with traumatic brain injury are not doing as well cognitively. And I'm not saying I'm doing any data gathering or anything like that.
Sure.
A story of mine where one of my NFL players, he said, go use my name, so I'll mention it, Paul Freeze. We become really good friends. And he had that issue with the brain-derived neurotropic factor that was, they call it altered. And he looked at me like, you really want me to take lithium?
So in this case, would you give him, just so I understand, that there's different types of lithium, right? There's lithium as a prescription. There's also lithium orotate, which you can get as a supplement. You're talking about prescribed lithium at this time?
I can definitely say I have a massive patient population. You think just because you play in the NFL that you have gobs of money. No. So I do work with people's insurance sometimes, but if I had my choice, I prefer people to take lithium orotate because that's physiologic lithium. Right. And that's not going to be dangerous to your kidneys long term. Right. But even prescription lithium, so long as you're doing a super low dose and you're watching it, and sometimes standard psychiatrists, they may see mutual patients and they're like, why is your lithium level so low? And my patients have to explain to them, this is not for bipolar, it's for brain healing.
It's for BDNF. So, gotcha.
Yeah. To increase BDNF. And then there's two other things that goes with that. But getting back to Paul, he just looked at me like, are you sure? I go, give it a try. And then 2 weeks later, he's like, I think I'm actually recognizing my thoughts. And I was like, okay, I'm not saying all that always works 100%, but I said, hey, it's worth a shot. Maybe that's the reason why you struggle with cognitive issues, along with everything else that I'm doing for him to,
of course,
brain heal and get his testosterone up without testosterone shock. So that to me is phenomenal already because that's standard medicine. You're low T. Shoot them up.
Yeah, no, I know. So on the genomic side of things, you find there's certain markers that are, again, there are some studies here, but a lot of this is on the clinical side for you. If you see their markers for BDNF are low, something like lithium orotate or prescribed lithium is kind of the way that you would go as sort of like your nutrigenomic equivalent of that issue, right? That's really interesting to me. I didn't know that. That's really cool. When it comes to like some of the nutritional deficiencies that you commonly see, either in traumatic brain injury or in others, are there I think that's the next step that you look at, right? You look at, and how would you typically test for those? Is it usually like testing blood, or is it urine, or how do you typically test for nutritional stuff?
There's a company that does it for us, and that's not the only one. There's but they were quasi-free if you did a certain kind of genetic test, like 23andMe and so forth. I don't do that for a lot of patients. I have them do a certain kind, but the thing is, if I do that, it's really interesting because I'm loading them up with D, and I'm like, why isn't your D, getting up there? And then they're like genetically prone to be poor absorbers.
Gotcha.
Even zinc. It's like I'm loading them up with zinc, and I'm like, why is this zinc not getting higher? You can gauge that from a clinical standpoint. You don't always have to run the genetics for that because now I learn that okay, this is one of those people that do that. And then I can even look at a lab work and say, you are a poor B12 metabolizer because B12 is a methylmalonic acid, so nothing's happening. So that's when you give methylcobalamin. And I would say a majority of people who are MTHFR deficient, people who cannot metabolize folate to L-methylfolate, that's usually the case. And I did have another integrative psychiatrist tell me, you should always do that, give methylcobalamin. And I'm like, why? Why should I do that unless it's warranted? Because it's not this rote protocol that I do. And I think this is why I'm really excited about doing what I do, because two people are like, not even twins who are born from the same womb. And I'm just looking at them too, like, why are you guys so opposite?
So you've had twins before. So you actually had some twins in the office?
Oh, yeah. Twins in the office. And then one's like, oh, I really want to do this program because you got him off this and that. And I go like, well, honey, you need those things. It's just really, really fun to be able to do that.
That's awesome. You have enough, you have a pretty big patient base and that's kind of fun. You get to kind of see even the variation between two people with identical genetics, right? But then they have all these manifestations that change. You were talking about in the beginning how treatment resistance in general is so high. And you pointed out that this being like very likely related to inflammation. When you're thinking about brain inflammation, I know Dr. Mark Gordon, who's also been on our podcast back when we first started, actually, we spoke a lot about this too, as well, as a way to help hormones and nutritionally as well, and the brain work better overall. If you're working on inflammation, what are some of the standard protocols that you use or that you do to help people overall with their inflammation in the brain?
So that's how I determined that. I created what I call my Brainwell program, which is Brainwell panel, which is everything. I look at
it's the genetics, it's the nutritional.
And then not only that, I look at their labs, like what are they deficient with, vitamins and whatever, and metabolism of vitamins, inflammation markers, and the hormones. You look at the brain hormones, because I'm not satisfied with why your T is low and here's a shot. Like, I need to know where it's coming from. Can we fix it another way? So that's how I go about with doing what I determine what each patient should have.
Right. So the inflammation aspect is related. How you're going to address that is related to the other aspects of what you're testing. And then that all kind of goes together as you're treating people. You mentioned hormones. And I think this is an important one that I didn't know a lot about before I met Mark many years ago, about the hormonal dysregulation that happens in traumatic brain injury. Like, I guess maybe to start off, like what's really common that you see in traumatic brain injury, or in maybe some of these other conditions like OCD or bipolar, if there's some interesting things to talk about there. Then from there, we can talk about things that you do.
Yeah, when it comes to like a traumatic brain injury, what I learned is when you have the chronic inflammation, it starts to make antibodies to the hormone control centers of the brain, the hypothalamus and pituitary. And that's how you wind up with low hormones. And I think it was one of the first integrative medicine lectures I attended. It was about traumatic brain injury. And I'm like, what does that have to do with integrative medicine?
Yeah.
If you are not getting anywhere with your Prozac, Paxil, whatever you're doing with your patient, you better be checking those hormones. What if that's the problem? And it's an amazing thing that I see in some of my patients, some of the veterans I do see, that they're doing great. And guess what? They're off their antidepressants because we figured out the problem was hormonal and inflammation.
Mm-hmm.
And now I'm getting these results that I have never seen in my patients.
Right.
And what I wanted to say was like, when you were doing traditional psychiatry, that's all I had. And so like, as you know, medications eventually either just quit working or they give you side effects, or even while you're taking the medicine, it doesn't work anymore. So I was always constantly changing medicines. And I'm just like, I think I need to figure out really where the root cause of all these issues are. And I have been looking at every patient that I've been through the past couple of months, and I look at things like, you realize you're not on a psych med.
Amazing. Yeah.
And they're like, yes, and I feel great.
That's got to be so satisfying, I would imagine, just because of all the years that you learned that was the only thing you can do. And now that you're addressing that inflammatory aspect, I didn't realize that it was an antibody reaction the whole time, or many times where you have sort of antibodies to the areas that were making hormones. So you see this, I'm sure, in real time, where as you're addressing inflammation, you're seeing these hormone levels get better, quote unquote, on their own without even having to use hormones sometimes, I would imagine.
Yeah. Sometimes when it's really that bad and they're really depressed, and I will figure it out, what supplements they're going to need to build their own hormones. But I have a patient that I was working with for 2 years because he was really that bad. Lots of brain injuries, lots of PTSD. And 2 years, it took me 2 years to get him stabilized. And we can talk about all the other ways that I did that, because in a way, what I like to practice is throw everything, including the kitchen sink, at the patient, and let's see which one works. But of course, with methods. But
of course.
They had low luteinizing hormone, low T, and we worked on getting the brain healthy, and the luteinizing hormone came back up. I think now we are pretty much just doing maybe 1 or 2 things to support the hormone balance. And I'm getting him off one of his antidepressants when he was on like high dosages of the SNRI and bupropion. It was bad with him. But now he's like, you ready to come off? And I checked on him and he goes like, yep, I'm okay with that SNRI. But he had a genetic issue where he is also a low dopamine metabolizer, as well as a poor methylator of folate. So in those kind of conditions, I call it the double whammy gene. Because think about it, if you cannot make your serotonin and dopamine, and then you're hypermetabolized on dopamine, no wonder you're going to get depressed. And then you tack on brain injury on top of that, which also prevents you from making your own neurotransmitters. And then, he had a lot of anxiety and PTSD with that. So you have to look at the whole picture. So I love it when patients do finally come in and commit to the Brainwell program, because I have to tell them, you know why you have not responded to your treatment? It's because ABCD, brain injury, hormones, trauma, and even toxins I've learned recently can cause just as much damage to the brain. And it's the same issue. The neurotransmitters are impaired, oxidative stress, brain cells are no longer working. And there's a couple of people that came to me because, we can talk about this because, one thing I don't think I really shared with you, Scott, was that I was trained in internal medicine and psychiatry. So maybe that's why I look at like things a little bit differently. Whenever I see a patient in the hospital, I run my thyroids and vitamin levels and all that, because it's like, you have to know those things first. And so it's kind of fun to actually go back to medicine and actually feel like you can actually do something for these patients. And fibromyalgia, it's like, oh my gosh, even one resident of mine, my senior resident, my first night, he's like, you don't want a patient with fibromyalgia because they're going to suck the life out of you. So I've always had this thing where like, oh no, run away. But now when these patients come in because they have mental health issues, they say fibro, I said, oh really? Humor me, let's run a tox panel on you. Let's see what's going on. And I've gotten patients' fibromyalgia to go away because of the fact that we gave them a detox protocol that's healthy, not expensive, not bad to the stomach. And so I've had some really good results with that. So I don't run away from it anymore. I'll be like, okay, this is what you have. I'm willing to treat you, but you're going to have to do what I ask you to do. If you're willing to do it, let's go. You know?
Yeah. No, I love that. And I think I do remember now that you told me that you did the internal medicine training first, and certainly you have the head for it, right? Which is you're looking at more of a comprehensive analysis overall. And now with your precision, with your BrainWell program, you mentioned the gentleman before with the double whammy gene mutations or the genetic stuff. Is that a pretty common one that you see in the office overall? Or if you do see it, it's pretty severe overall when they're presenting?
Okay, this is the thing. Once I really understood genetics, I started looking back at all my patients like, OMG, this was their problem. That's why I couldn't help them. And that's why they got worse with whatever I gave them.
Yes.
You know, it's like,
yes.
Or I'll be like, no wonder they were so hateful, you know, and because that complicates things. And so I'm going to be honest, like I would say 80% of my patients have something going on with their genetics.
Well, yeah. I mean, I would imagine it's high. I think about the MTHFR specifically as in almost everybody has some problem with that particular gene. So as a result of almost everybody having an issue, I don't know if it's like the major issue for most people, but if you have a brain injury, if you have some of these other concurrent issues that are going on, like you talked about BDNF, dopamine metabolizing, those kinds of things, I think it's probably like this sort of double, triple, quadruple whammy kind of thing. And then they're going to be ending up at your office after seeing other psychiatrists that couldn't help them at all. And now they're with you. I would imagine it's probably more of like a combination of things, of course, rather than just MTHFR for sure.
Oh, yes, for sure. Because you have to consider dopamine metabolism when you have MTHFR deficiency. So now I'm going to be like, if you don't have that in your genetic test, I need for you to redo it because I'm not going to give you L-methylfolate unless I know where your metabolism of dopamine is. Because even at low dosages with some of my patients who have MTHFR deficiency and low dopamine metabolism, I give them half a dose of the normal L-methylfolate. They're still anxious. So I warn them. It's like, you may still be anxious. So like, just don't take it. So sometimes in those cases, I don't even really push for them to take L-methylfolate.
So if they're having issues with their dopamine metabolism, you'll actually not be able to supplement them with L-methylfolate in that case. Interesting.
Yeah. And then in those cases, I normally go with something like 5-HTP, which becomes pure serotonin.
Right.
And I learned this from Dr. Greenblatt. He runs an integrative fellowship. He is phenomenal. He knows his molecules chemistry. I've never seen anybody teach me. He's the one that taught me, like, don't do tryptophan because that's going to shut down your serotonin production. You got to do 5-HTP. And the thing about 5-HTP, if you give that to a patient in the regular synthesis of neurotransmitters, it will take away the dopamine synthesis because you add that on there to SAMe, so it becomes more serotonin. And so you're taking away the production of dopamine as well. So that's why I will go with 5-HTP for some patients versus just L-methylfolate.
I wasn't actually familiar with that mechanism. That's really interesting. So if you're giving 5-HTP, you're actually decreasing dopamine levels as well as increasing serotonin at the same time. Cool.
Yeah, because it's, it's sort of like a rate limiting step. Here's this chemical reaction going on. But if you're throwing 5-HTP in there, what's chemical reaction going to do? It's going to go to serotonin versus dopamine.
I love it. Yeah, this is the intricacy of the neurohormones and neurochemicals and things, and it's just so fascinating to me. I think one thing I wanted to ask you about as well is one very challenging thing, which is how do we wean patients off of antidepressants? Now, let's say that like they're ready, right? They're, for whatever reason, you've worked on their foundational brain health, their inflammation, their hormones are getting better, all those things. So not that's easy. It can take years, as you said. But do you have a framework and that you use to get somebody off of an SSRI or SNRI that they've been on it for years or longer? How do you typically do it?
Yeah, this reminds me of a patient that just came in today, and she came to me because she was tired of being on a Prozac. And I said, okay, but you got to do what I asked you to do. Let's run your genetics, just run your hormones, and let's see what was that Prozac doing? Because like that was like the go-to medicine. It was called Seraphim. And when it came to treating people, women with menopause, which really was not all that effective, or maybe it was because they're no longer going like this, but they're like, I'm flat, I don't care.
Right. Yeah.
That was the medication to give women in menopause, which was totally wrong, but that's all I was taught to do. So that's what I did.
Right.
But now going through the integrative model, adding precision psychiatry with it, I now know what's going on with her genetics. She had a problem with MTHFR deficiency. And so I was like, okay, let's, it's going to be a long haul. I think I've been working with her since December last year.
Okay.
And she said, I can never get off my Prozac. Every time I try, my anxiety goes all over the place. So I said, all right, we're going to do it slowly. And I found out she is MTHFR deficient. So I said, okay, let's give the L-methylfolate. She's been on for about 6 months now, and she has been weaning off her Prozac. And she does it slowly, like every month, like one down and all that. Right now, she's like once a week. And she's like, I'm doing okay. But yeah, I do have feel a little bit of anxiety still. It's like, I don't know where that's coming from. It could just be hormonal, maybe. But she goes, but I'm doing fine, because we found out really what the root cause of the problem was.
Yeah, I get it. And that's really important. Part of the interruption. This episode is brought to you by Transcriptions, makers of precision dose, physician formulated, and pharmaceutical grade formulas in the form of a buccal trachea. For this episode, check out our Just Blue. This is 16 milligrams of pure pharmaceutical grade methylene blue in troche form. Titrate your dose. Start with 4 milligrams, just 1/4. Then increase your dose every 3 to 5 days until you start feeling better, because you will. It's a fantastic mitochondrial optimizer, increasing energy and increasing resilience. If you're interested, go check out Transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show. So when you think about the weaning schedule in somebody, do you have a standard like weaning schedule that you will typically do? If they're on, will you decrease it like 5 milligrams a week, a month, or does it depend on? Obviously, it depends on the patient to some degree, but do you have a framework that you kind of use?
Yeah, normally we can get patients off their antidepressants within a month, like every other day, 3 times a week, 2 times a week, and one day. And then usually that gets them off their antidepressants.
Okay.
But in this case, it took her months, because everybody is different. And I always tell my patients, though, if you're not tolerating it that way, then just stay where you are. And sometimes I will have to go months. Like, okay, we're going to go every other day for a month and see how you do, and bring it down the next month, bring a month. So it just really depends on the patient. And it's just kind of funny, though, because everybody is different. And when I was treating this veteran and he was on venlafaxine, like he was doing, we didn't talk about this transcranial magnetic stimulation.
Yeah, I'm going to ask you about that.
He was a veteran, so he had a brain injury. And then once he finished out treatment, then I noticed, he had a lot of hormone deficiencies. So I started him on whatever it took without testosterone to get his, hormones up. A month into the treatment, he's like, Doc, I stopped my venlafaxine. I was like, what? And I said, you can't do that. I was like, why? I'm fine. I don't know if Scott, venlafaxine is one of the hardest medications to get off of.
Yes, I do know. Yeah.
And it was like,
he just stopped it.
But he was like, and I feel good. And I'm like, okay, but like, I wouldn't have done that. But if you were okay with it, because the protocol that we did, get your brain healthy, get your hormones up to where they were, is keeping you from getting depressed. And so that is, so everybody is just different. And that's why I see patients every 2 to 4 weeks to make sure that they're doing okay with whatever we're doing.
Yeah. I mean, I think that's really great to hear, is that it really is very variable. Some people, you can get them off very quickly, over a month or so with weaning down. Sometimes it can take 6 months or a year or longer, depending on their symptoms, but you're doing it by symptoms. You're doing it by how they feel. And then you can slow it down, stop it, reverse it, whatever it needs to be along the way. And I think that's hard for patients, because they just want to get off as fast as possible. And of course, you're also doing all the foundational stuff. You're doing all your whole framework at the same time to do it. And then occasionally you get the one person that just stops it and they're fine, but that's pretty unusual.
Yeah.
So you talked about venlafaxine being one of the harder ones. Are there any other ones that are in that category that are also very difficult to get off of typically?
Paroxetine is also really bad.
Okay.
And ironically, the patient I spoke about that was on Prozac, I was like, I don't know why you're having such a hard time getting off the Prozac, because Prozac stays in your system for a week. But everybody is different, especially if you have genetic issues. But yeah, paroxetine, that is something I would never recommend to people. Like, don't suddenly stop that unless you found another replacement for it.
Yeah.
Yeah.
And this is kind of more of an interest, and if you don't have an answer for this, it's totally okay. I found that over the years using hyperbaric medicine, that there were certain psychiatric drugs that if the patient was on, they just wouldn't get better. And I don't know why, but like if they were on Cymbalta for whatever reason, or Effexor, specifically those two, like even if I thought they should get better for their brain injury, for example, they just wouldn't. I think this goes to show us that there's a lot more at play here, right? There's not just about getting into a hyperbaric chamber, as you very well know. But I was curious maybe if those two drugs are especially difficult to get off of. At least it sounds like Effexor is.
Yeah, the venlafaxine is one of the hardest ones. I think duloxetine, Cymbalta, it lasts a little bit longer. So you don't have that much problem, with getting patients off of that.
Yeah.
But like that's interesting that you tell me that, because what I think about SNRIs, it's actually one of the better medicines to increase brain-derived neurotrophic factor.
Interesting. Okay.
So yeah. So like I have to really look into that. That is just
it was just anecdotal. I just had some patients, and I was just like, why aren't these people getting better? But I mean, I think like you said, there's so many aspects to this, right? And we've talked about a lot of them. One of the aspects I wanted to ask you about that we haven't discussed is actually the therapy part of it, everything. Are you integrating therapy into all this as well, as far as talk therapy and into your practice, or do you refer out to other people to do some of that, or how do you integrate that into what you do?
Yeah, it really depends on the patient. Let's just say that anxiety is even harder sometimes to treat than depression.
Yes.
Because anxiety requires higher levels of serotonin. And sometimes people want to treat anxiety because they can really just get in their own way. Okay. They don't trust anything. They have to Google everything. They have to I don't know about that, doc. And I see this a lot in people with our low dopamine metabolizers. Okay. We have to just look at what we need to do to get the patient to where they need to be. That is the thing that we need to do.
And I think that's beautifully said overall. It's really so heterogeneous. And the reason I ask is I was thinking about when you see a lot of people with like trauma, for example, like a PTSD, I know that therapy can be really, really helpful for these patients, like in various ways, like referring over to EMDR or something like that, if they have a need. And then my corollary to that was your thoughts about, let's call it the psychedelic renaissance now, in the sense of using like ketamine, psilocybin, other things that are being used in this space. Do you have any opinions or thoughts about that in the setting of other types of therapy that might be helpful?
Yeah, I started looking into ketamine and psilocybin. I think the jury is still out with that. I do see that ketamine, it actually helped one of my patients because she got it from treatment elsewhere. But it finally did get her out, ironically, with her anxiety, because I was able to get her depression, treated with just giving her TMS. But anxiety was still way up there. But interesting enough, with ketamine, it does also increase the BDNF. So I said, maybe that's why she did well with it too, because she needed a ton of brain heat. And when you talk about anxiety and even PTSD, it's really good that I can refer people to a therapist, because when you do that, this is where the integrative model comes in. It's not just supplements. It's just not meds. It's not just transcranial magnetic stimulation. You got to get the patient to start thinking a little bit differently. Get them out of that hamster wheel that they can't get out of.
Right, those cycles,
And then also with PTSD, yes, EMDR is very effective. And I use therapy as part of what I do to help patients get better. The unfortunate thing about therapy is that if they are so impaired, cognitively impaired, so depressed, they're not coming out of their house, and here they are, I do telemedicine and they're like in a dark room. I can barely see them.
Yeah.
So you have to get them to a point where they will start functioning and getting out. And then cognitively they are in a better state to get them to do therapy. So that's where, I use the model of do what you need to do. And then we also do utilize nutritionists that kind of understand all the supplements I give them, because some nutritionists are like, well, you should eat more protein. And then they're low dopamine metabolizers. And I had a case like this where like the patient said, yeah, the nutritionist told me I needed to eat a ton of protein, but then I realized what I am. So I read your treatment plan again, doc. And I was like, I felt really bad when I had too much protein.
Interesting.
I can't low dopamine metabolism. And so I'm just going to stick with what you have. And I don't feel so inflamed anymore. You know,
it's beautiful.
So yeah,
okay.
Yeah. So nutritionists that understand the protocol, as well as understanding people's genetics, that, you know, you have to make it unique for them, because no two people are alike. And then I even employ a life coach, because if you have traumatic brain injury, what's going to happen? You get confused, you get overwhelmed, because sometimes in the beginning they may have 10 supplements. And eventually, once the program is over, when the year is over, we get them down to like maybe 2 or 3. But we needed to do that to get their brain to where they needed to be. So do I refer people out for other treatment modalities? Yes. If we've tried everything, that's not working. And that's why I asked you, Scott, to create me a protocol for hyperbaric.
Right,
and thank you for teaching me that I can't just throw people in there.
Yes.
Without thinking about their aerobic infection.
Yes, it's an intentional way of thinking about things, just as you do on the integrative or the precision psychiatry side. One thing additionally I wanted to ask you before we finish up was around TMS. You mentioned it a couple times. Mm-hmm. What has your experience been with it over the years? Where do you see it shining? What do you see as like the future, or like some of the maybe off-label indications where you've seen some significant benefit?
Yeah, I'm a kind of person who does not jump on the bandwagon for things. Because when I did that early on in my career, it didn't work out. So even with TMS came out, I think it's been around since my tech. But even then, when it started to be relevant in clinical practice, the insurance were finally paying for it. It's like, I am not investing $100,000 in this machine unless I'm convinced. And so finally, you get into the end road with medications. I'll be like, listen, I'm going to send you to my colleague who does TMS. And majority of them came back and said, wow, that was great. And I said, oh, okay, maybe I should start doing it. So that's when I really was convinced that it is a treatment for treatment-resistant depression. Normally, even with TMS, you have a 60% success rate. But with our program that we do, because you can't just throw TMS into a patient.
Sounds familiar. Yes, like a hyperbaric chamber. Yes. Yeah.
Yeah. So I need to know, are you a poor dopamine metabolizer, or are you a high dopamine metabolizer? Can you make your own neurotransmitters? Because what happens with TMS, it's electrical activity that goes to the DLP part of the brain where all your neurotransmitters live. What if you can't even produce those things as well as you should?
Right.
So I think that's really where TMS falters, because we're not thinking about that. Or they have traumatic brain injury. Can we get this patient's brain to be less inflamed? And so this is what I also noticed too. If you don't address the inflammation in a patient with TMS, they're not going to respond to it the way that they should.
Yes.
Inflammation is always the barrier for a lot of the treatments with any kind of psychiatric medications. TMS is good for depression, but then we also use an anxiety protocol. Supposedly, it's the right side of the brain where anxiety lives. Okay. So we do that. We map here, and then we go on the other side. And then it's also approved for OCD. And that's a little bit harder to do because it's a little bit higher power. But you can use it for that. And somebody told me, it's supposed to be helpful for nicotine. But what I use it for is treatment-resistant depression, comorbid anxiety, comorbid traumatic brain injury. Because when you talk about a patient with traumatic brain injury, they are going to be treatment-resistant depression. And that's really why they wind up at my doorstep.
Yes,
and
yeah.
And then, just listening to their story, I got a treatment that you will need because you've been on 10 meds and, you have a brain injury. I didn't know that, doc. And I'm like, yeah, you've fallen. Or even if from the womb or a birth, trauma, that can set a patient for life for chronic
Absolutely.
depression.
Absolutely. Yeah.
And they don't have any family history of it.
Yeah.
So
Yeah.
there's a lot more to it when it comes to TMS. I really think that it can help with not just depression and anxiety and traumatic brain injury. There's a lot more to come with that in the pipeline. And I think like we're probably going to start doing some data gathering ourselves to see like what we can use it for. So I'm excited about that.
I love it. Mizyl, this has been great. Thanks so much for spending some time with me. You did a great job, by the way, for your first podcast. I think what's easy is that you have so much clinical experience, right? So you know down to like the patient, like, oh, I saw this patient yesterday, this patient 2 days ago. That's what I love about being able to host this, is like bring people on like you and say, these are people that are actually seeing patients in real time in their practices and seeing results by doing the methods that they've developed with a lot of help and support along the way. But it's not just one thing. And I always talk about this with hyperbaric therapy. You just mentioned it impressively and succinctly with TMS. It's like if you put them in there and flame, they're not going to get better. And I could say very similar things with hyperbaric therapy. So if anybody was interested in learning more about your practice, becoming a patient, or anything that you're doing right now in the world, where would be the best place to send them?
They can go to my website, paradisebehavioral.com. And then I'm actually going to host a webinar next Thursday at 7:00. This is really for patients, because I don't think patients are even aware that this is an option in our practice, because they see my NPs and so forth. But I want everyone to be aware that there are other options out there if you're just tired of meds. Okay. But yeah, they can go to the website, paradisebehavioral.com. And if they want to sign up for that, there's a link in there too. And I can quasi see patients that are not in the state of Florida, but it has to be in a certain way that we have to limit what we can do.
Sure.
Because if you're just asking me to analyze your labs and analyze your genetics and what I think you should do, I think I can do that for consultation.
Right. Sure. Yeah. Well, I think that's great. I think you're just kind of starting your evolution. You have a very busy practice with MPs and therapies and so much going on. It's great you're also educating the community. So thank you for educating me today. Thank you for educating our community here. And I hope to see you sometime soon at a conference nearby, one of us. Maybe.
Yes. Maybe. All right. I'm going to bring you to one of those.
Okay. Be well. Have a great day, Mizyl. Nice to see you. Take care.
Thank you. All right, Scott. Nice seeing you. Bye-bye.
Thanks so much for tuning in to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. I had such a great time recording with Dr. Mizyl Damayo, a friend and colleague. And again, this is her first time ever on a podcast. She did really, really well. And her framework, the Brainwell framework that she's developed, is so robust and so important from a mental health perspective that everybody needs to know about this. And I hope you will refer your friends and colleagues to listen to this episode so they can learn about it too. It's not rocket science in its basics, but the intricacies and nuances are real. And we talk about a lot of those in this podcast. So if you like this, please don't forget to like and subscribe below, share with your friends and colleagues, and we can't wait to see you next time on another episode. Take care.